We're going to talk about CPAP and BiPAP, or non-invasive positive pressure ventilation. I was asked by one of the medics to go over this, and this is something that I think is important, and I'm glad that he asked me to go over it. But people in acute respiratory failure will usually have a problem with oxygenation or ventilation, or sometimes both. And oxygenation, if you remember back, is just basically the process of providing oxygen to the patient. And then ventilation is actually the actual process of breathing, the inhalation, gas exchange, and then exhalation. So it's not just oxygenation. And the patient in respiratory failure may have oxygenation problems, but they also may have ventilation problems. And usually the ventilation problems is usually a mechanical issue. They've got a flail segment, they've got neuromuscular problems that they just can't control their respiratory muscles, but many times it's an alveolar issue. You have a disease of the alveoli, either from COPD, in which the alveoli are just not very elastic and they're collapsed, or you've got fluid or hemorrhage from traumatic injury, but most likely congestive heart failure, pulmonary edema. You got fluid in those alveoli. So ventilation really becomes important in respiratory failure due to alveoli problems. So you really got to help with that gas exchange. So non-invasive positive pressure ventilation, as we all know, is basically providing positive pressure ventilation without intubation. Intubation and a ventilator is a form of positive pressure ventilation, but it's not non-invasive. So non-invasive, there are two types. There's CPAP and BiPAP, and there's some other issues coming out with some variations of BiPAP. But basically, from what we're going to talk about today, CPAP and BiPAP are two non-invasive positive pressure ventilation modalities. So most of us in the field use CPAP. Some services use BiPAP. But as you can think of, CPAP is basically providing primarily oxygenation. It may indirectly assist with ventilation by preventing some alveolar collapse, and it keeps the alveoli open. And it may even recruit some alveoli that have been basically collapsed. So if you think about CPAP, helps with oxygenation, but because of that pressure coming into that airway, it just basically inflates those alveoli. You can think of it basically as blowing up a balloon. A collapsed alveoli, alveoli that just collapse on itself or has fluid in them, are not very useful for ventilation and gas exchange. So they really need to have air in them, for lack of better terms, be blown up some. So CPAP will actually keep those alveoli open because of that pressure, and those that are already collapsed, it will actually sometimes recruit those and make them inflate. So that's a simplistic way of understanding what the alveoli do and what CPAP does. With CPAP, and we're going to talk about BiPAP in a few minutes, but with CPAP, it's a constant pressure. You've got, and we're just going to use a term, let's say 10 centimeters of water. You've got 10 centimeters of water that's blowing in to the airway, and 10 centimeters that are coming, they're still there when you exhale. The problem with CPAP is that that 10 centimeters of water blowing into your airway is really helping you, but somebody's already in respiratory distress, they're having to overcome that 10 centimeters of water to exhale. So they're actually having to breathe basically through a straw to exhale, and that can be problematic sometimes. BiPAP, on the other hand, is what we call bi-level positive pressure, and basically it provides a higher pressure going in that will help basically recruit those alveoli, keep those alveoli open, but then it senses basically the respiratory effort of the patient, and it will lower that pressure so that the patient can blow out and exhale against a lower pressure. So you can think, rather than sort of a CPAP blowing out against a straw, you're basically blowing out against a bigger straw, and you're able to get your basically air out easier with BiPAP. BiPAP also will help with oxygenation. So BiPAP is something that you probably will see used more in the hospital than in the field, but some services are actually using BiPAP in the field as well. So let's talk about BiPAP and CPAP and which one is better. If you look at routine medical treatment for COPD, bronchitis, etc., and when I say routine or standard medical therapy, that is oxygen, bronchodilators, albuterol updraft, antibiotics, steroids, and you'll see us use that in the field. There's no doubt that BiPAP is better than that standard medical treatment. You have someone that comes in hypoxic, they're in respiratory distress, and you give them those steroids, those antibiotics, that oxygen, those bronchodilators. BiPAP will help those patients quicker. It will keep those patients that routinely would deteriorate and need intubation from that standard medical treatment. It will decrease the incidence of intubation. It will decrease mortality. It will decrease ICU admissions. It will decrease length of stay, which is important to us in the hospital as compared to that standard medical therapy. But what about BiPAP and CPAP? Which one is better? Well, again, if you look at just BiPAP, it's better than just oxygen and steroids. But many people have said over the years, well, I think BiPAP is better than CPAP. Some people will say CPAP is better than BiPAP. And I have always been one that as soon as the ambulance will bring in a CPAP patient, I will take the CPAP off in the emergency department and put them on BiPAP, because I've always thought that BiPAP works better than CPAP. Well, if you look at the literature and you look at the studies, study after study after study have shown that BiPAP is not superior to CPAP. They're almost identical. So really, CPAP is just as good as BiPAP. Now, what BiPAP does do is BiPAP makes them better quicker. And sometimes I think from a patient standpoint, we want to make them more comfortable quicker. So BiPAP does make them better. It improves their oxygenation. It reduces or reverses their acidosis, their respiratory acidosis quicker. It makes their vital signs better, quicker than CPAP. But the long term, hour down the road, BiPAP and CPAP are almost identical in alleviating the need for intubation, alleviating the need for ICU admission, length of stay, etc. Again, I'm not a very patient person, so I want to turn them around very quickly. So the BiPAP does turn them around quicker. But if you don't have BiPAP and you only have CPAP, then I certainly think that long-term CPAP is just as good as BiPAP. That was really surprising when I started looking at this, because I've always thought that BiPAP was much, much better than CPAP. And again, in the short term, it does turn around quicker. Long term, it does not. All right. So, some people will also tell you that BiPAP may be a little bit better in COPD and CPAP may be better in CHF. Again, if you look at the studies in both of those, COPD and CHF, both of them, long-term BiPAP and CPAP are about equal. So, bottom line, there's no clear advantage over BiPAP versus CPAP or CPAP over BiPAP. Clinically, from our standpoint, BiPAP is much superior than just normal treatment with oxygen, steroids, antibiotics, bronchodilators. But long-term COPD, CHF, BiPAP is just as good as CPAP. I think the key, if you're going to use either one, is to use it early. If you get on the scene, the patient's hypoxic, sats are low, they're breathing 40 times a minute, you can hear rails, then you need to put that CPAP on them. I found over the years that if you wait longer, you can't turn them around and they will need intubation. So again, I see many times that we'll come in and we really haven't picked up that the patient's in congestive heart failure. Patients got rails, patients got JVD, patient tells you that they can't breathe laying down, they got orthopnea, they got leg swelling, they got a history of CHF. It's really important to take this a history. So if they have that, or the COPD patient, then again, make sure that you get these people on CPAP. If you're using BiPAP, fine. Get them on something very quickly. The longer you wait, harder it's going to get to turn them around. But I do think that CPAP and BiPAP both have changed the game in pre-hospital airway management, and even in the emergency department, in keeping these people off the ventilator. So familiarize yourself with your CPAP machine or BiPAP, and again, use it early. Thank you.